While giving an assessment, there are three types of questions you ask to obtain relevant information for the treatment plan: general, specific, and pain questions. General, specific, and pain. Which of the following is a specific question? What aggravates the pain? Was there medical treatment or therapy given prior to coming to get a massage? Is there a family history of the presenting complaint? Exactly where is the pain? So which is specific? What aggravates the pain? Was there medical treatment or therapy given prior to coming to get a massage? Is there a family history of the presenting complaint, or exactly where is the pain?
Was there medical treatment?
Yes. Yes. And how do you know that this is the only one that's specific?
Because of the medical treatment part. Like
Okay,
just
because the medical treatment would be specific to the condition. I see.
yeah.
And wouldn't conditions or things that aggravate the pain, wouldn't that be specific um, to the condition?
Yes, but I figured that was more so pain since it has the word pain in it.
Good thinking. And how about family history? Does that sound specific to the
Um,
condition that they're complaining about?
Not as specific as the one we picked. And then exactly where's the pain is more general, I think.
Yep. Great, great. Yeah. And then exactly where is the pain would be, again, probably a pain question, right? Cool. Okay, here we go. Which of the following techniques is focused on the connective tissue structures to influence posture and biomechanics? Which of the following techniques is focused on the connective tissue structures to influence posture and biomechanics? Is it Rolfing, trigger point, Traeger, or reflexology? Rolfing, trigger point, Traeger, or reflexology? I'm guessing since it mentions connective tissue and posture and biomechanics, I'm guessing it's Rolfing. Let me know if you need further information about any of these. A client has been training for the Ironman triathlon. It is a month and a half away. She's been swimming her whole life, so the 2.4-mile swim is not a problem. The goal to be proficient in the 112-mile bike ride and the 26.2-mile run was almost obtained. 6 mornings ago during a run, she felt a painful pulling in her left Achilles tendon area. She didn't want to ruin the chance to compete in the triathlon, so she walked home and iced the area right away. She can walk with low pain and swim just fine, but if she cycles or runs, she can feel that painful pull. On the following treatments, which would be the best application to achieve greater flexibility, range of motion, and to help relieve your client's painful pull? Aston patterning, active isolated stretching, Alexander technique, or acupressure. Greater flexibility, range of motion, and help relieve the pain. Aston patterning, active isolated stretching, Alexander, or acupressure.
Alexander technique,
Okay, why do you think Alexander?
range of motion.
Range of motion is definitely part of Alexander, but not in the same way as things like stretching.
Uh,
Its goal is not really to increase range of motion, but that does happen through better posture, better use of posture and
oh,
alignment.
that's right.
And there's an exploration, a self-awareness, and a self-education that happens through Alexander technique. And it's not mentioned here. So let's eliminate that one, Larissa. And let's try again. Greater flexibility, range of motion, and pain relief.
Would it be active isolation stretching?
Probably. And why do you think that's the answer?
Because of what you just said.
You can't say what he said
Oh, sorry.
in your head when you're taking the exam. You have to have a rationale.
Jesus.
What do you think? Sounds like you cut out. Okay, so active isolated stretching, because it provides stretching of major muscle groups, therefore it works on flexibility, right? Also range of motion, which is related to the joints more than the muscles, in my opinion. And then the relief of the painful pull, obviously by lengthening the soft tissues and opening the joints, increasing joint range of motion, that also reduces pain. Okay. We might as well go over these while we're here. Okay, it's like a good thing to do at the beginning of the lecture, beginning of the night. So Aston patterning is, let me get you the good definition of that. So Aston patterning uses many modalities, including movement. Here you go: massage, movement education, fitness training. Oh, sorry. Fitness training, and I think proprioception, as well as environmental modifications. Okay, so okay, one last time. Aston patterning, it's very comprehensive. It includes massage, postural education, active isolated stretching, focuses specifically on flexibility and the range of motion and results in relieving pain. Alexander technique is a method that encourages your self-exploration, self-awareness, so that you can find greater ease in how you sit, stand, move, and walk, how you use your body. Acupressure is, let's see, how are they defining that? With things like acupressure, you have to be really specific. A traditional Chinese medicine working with meridian points. They also defined it, Yugo Prep, this is a Yugo Prep question. They also defined it as a modality that uses the body's natural healing ability, or enhances the body's natural healing ability. Okay, on we go. A client complains of pain in their ribs on the right side whenever they rotate to the left. They have well-defined abdominal muscles with moderate posterior pelvic tilt. Your PA shows a moderate increase in thoracic kyphosis. What muscles are shortened? PA is physical assessment. Your PA shows moderate increase in thoracic kyphosis. What muscles are shortened? Pain in the ribs on the right side when they rotate to the left. And the ribs on the right side touch your right side and turn to the left when they rotate. Bilateral pectoralis minor, bilateral trapezius, bilateral rhomboid major, bilateral rhomboid minor.
I think it's one of the bilateral rhomboids, but I don't know if it's major or minor.
Okay. Well, it doesn't tell you whether or not the pain in the ribs is the anterior side of the rib cage or the posterior side of the rib cage. It doesn't tell you that. It does tell you that they have well-defined abdominal muscles.
Oh, so it would be the pectoral. Yeah.
Who knows? Who knows? But what muscles would shorten in the? Let's name as many as we can think of in the front and the back. So if we're turning to the left, twisting through the trunk toward the left, what muscles would shorten? Would it be the rhomboids on both sides? Oh, I'm sorry. No. What muscles are shortened implies chronically tight, I think, not shortening as a result of the movement. I'm sorry. So it's not going to be a specific muscle that shortens as a result of twisting. So let's just take a guess. So we'll go with one of the rhomboids. Let's see what the answer is. It's the pectoralis minor. Let's see the rationale. See, questions like these that are vague, they're useful because they teach you a way of thinking about the exam. So posterior pelvic tilt shortens the posterior thigh, and the abdominal muscles, lengthening the anterior thigh and the muscles associated with cervical spin. The external obliques are opposite side rotators, and the internal obliques rotate to the same side. The shortened abdominal muscles also increase thoracic kyphotic curve, lengthening the rhomboids and trapezius and shortening the pectoralis major and minor. The shortened abdominal muscles also increase the thoracic kyphotic curve, lengthening the rhomboids and shortening the pectoralis major and minor. So you guys, to feel the kyphosis, right? You exaggerate your kyphosis. Remember, kyphosis is the curve in the thoracic spine. It's a natural occurring phenomenon. But if it's exaggerated, there's a lengthening of the muscles in the posterior and there's a shortening of the muscles in the anterior surface. So of these, which muscles are shortened, meaning chronically shortened? It's the pectoralis minor rather than the traps, rather than the rhomboids. Now, it's a poorly worded question, right? It doesn't tell you whether that's chronic or chronically shortened or shortening as a result of the movement of the twist. It's not telling you whether or not the muscles are in the front or the back, or the pain even is in the front or the back. And like the twisting thing to me is just confusing because there's the external and internal obliques that aren't even options among the answers. And the bilateral trapezius could definitely be tight in a number of situations, but especially in thoracic kyphosis because people are working a lot with their hands in front of them, typing and stuff like that. So this is a poorly worded question, and it's good for us to go through questions like that, to have questions like that. Hopefully questions like this won't be on the exam, but if you can see the anatomical, the kinesiology thinking behind it, you're one step closer to having a correct answer. Okay, which of the following three muscles of the leg run posteriorly to the medial malleolus, to their insertion on the foot? Which of the following three muscles of the leg run posteriorly to the medial malleolus? Touch your medial malleolus. That's the ankle bone on the inside of the foot. And which muscles are behind that? Which muscles are behind that? And then insert into the foot. Is it the tibialis posterior? Possible. Extensor hallucis longus? Definitely possible. Extensor digitorum longus? Not possible. Extensor digitorum longus is, I believe that's also the peroneal muscle, which is on the lateral side, not the medial side. So it's not A. Tibialis anterior? No. Tibialis posterior, extensor hallucis longus. Yeah, those last two. Okay, Larissa. Can you read the next one?
I can't see the whole answer.
Oh, okay. You have a sore throat?
Yeah.
Not a good night to read. That's okay, don't worry about it. Charday. Charday, your headphones make you sound a little muffled.
Oh, sorry.
FYI. Let's see. No, it's okay. Let's see how this does. Can you see this?
Yes.
Okay. Go ahead and read that, please.
Tibialis posterior, flexor digitorum longus,
Yeah.
and
Yeah.
flexor hallucis longus.
That's right. What do you think? Could these be they?
Yeah, I think those are it.
Yeah, definitely could be. All in the posterior compartment, right? And then tibia, and then the last one, tibialis anterior, extensor hallucis longus, extensor digitorum longus. So I don't think it's either of these extensor muscles. Let's see what the answer is. It's a tibialis posterior, flexor digitorum longus, and flexor hallucis longus. If you guys see a muscle, hear a muscle, and you want to see an anatomy drawing, just let me know. Okay? Otherwise, I'm going to keep moving. What type of trigger point is found in muscle that lies within the referral pattern of another trigger point? What type of trigger point is found in a muscle that lies inside the referral pattern of another trigger point? Is that the active trigger point, satellite, the latent, or the primary? The answer should be satellite. Satellite trigger point is found in muscle that lies within the referral pattern of another trigger point. An active trigger point is painful at rest with movement of the muscle and with a passive or active stretch. Latent only produces pain when palpated. A primary trigger point is directly activated by acute or chronic mechanical strain or overload of the affected muscle. Ron is on a soccer team. Last week, he went for a side kick at the same time as a defender and got kicked in the left calf muscle. He iced it right away, and every day since, there is no visible bruising, and it didn't seem as if the kick was that hard. Now, when he walks and runs, he still feels as if something is holding the muscle in an activated position. From the following treatment techniques, which is the best application that will increase range of motion and align the muscle tissues? Increase range of motion and align the muscle tissues. Is it Aston patterning, Alexander technique, acupressure, or active isolated stretching? I'm going to go for the AIS, active isolated, and we have a winner. Again, they're asking about increasing range of motion and aligning muscle tissue. That is pretty simple. Stretching of the major muscle groups and lengthening, releasing the fascia. And also avoiding reflexive contractions by the antagonist muscle group that stretches repeated no more than 8 to 10 times. That's good. Okay, and then as a reminder, acupressure works with meridian points. Alexander technique, they summarize it as postural education. Aston patterning includes multiple modalities: movement, massage, fitness training, postural evaluation, and environmental modifications. And next, what is the name of the test given to assess thoracic outlet syndrome, TOS, for the anterior scalene muscle? The name of the test given to assess the thoracic outlet syndrome for the anterior scalene muscle. Was that Adson's test, Travell's test, ostoclavicular syndrome, or Wright's hyperabduction? That's Adson's test. It's done by having the client in the seated position passively extend the affected arm and then add slight external rotation. While standing behind the client, the monitor the radial pulse of the arm, have a client rotate their head toward the affected side, slightly elevating the chin, and take and hold a deep breath for 15 to 20 seconds. Elevating of the first rib with the breath compresses the neurovascular bundle up against the hypertonic anterior scalene muscle. Did you guys follow most of that?
That's a real test. I mean, well, of course, there's a real test, but are all of those on their test?
Ostoclavicular syndrome is not a test, but these are tests. So Adson's is the anterior scalene, Travell's for the middle scalene, Wright's hyperabduction for the pec minor. Ostoclavicular syndrome is clavicle and first rib compression. Do you guys want to look at these tests, or do you want to look at a video of Adson's test?
Yes, please.
Yes, please.
Okay, let's see if we can do that. So arm in abduction with external rotation. Arm in abduction, so the arm in extension. So the arm is actually behind his side, right? So this is extension, right? I was going extension like this. This is actually flexion, and I was thinking abduction. So this is extension, right? It's got it behind him. And then external rotation. So the thumb is moving like this. So reach behind you and then go thumb up, thumb back. That's extension, and then external rotation. And then he's having the client move the chin in a specific way. And that is extension of the neck and then looking toward the affected side. And he's monitoring the pulse. The pulse will be occluded or slowed down if there's compression in the anterior scalene area. Seated position, we saw that. Passively extend the affected arm and then add a slight external rotation. We saw that the arm is extended behind him and rotated externally. Standing by the operator or therapist, that's you, standing behind the client, monitors the radial pulse of the arm. Notice he's got his hand therapist has his fingertips on the radial pulse of the client. Have the client rotate the head toward the affected side, that's the right, slightly elevating the chin, and take and hold a deep breath for 15 to 20 seconds. And let's look at Travell's test. I'm not seeing Travell's test, middle scalings. Yeah, I'm not seeing anything direct for Travell's test. This looks like the test we just saw, right? Okay. All right, we did our due diligence, right? We looked for the test. So now we're familiar at least with Adson's test. Okay, if your client is suffering from chronic, just stop me and say, no, wait, go back, I want to finish this up. If something feels incomplete, let me know. If your client is suffering from chronic varus stress, what ligament might be damaged? Varus valgus, right? One is knees in, one is knees out. Is that the posterior cruciate ligament, the lateral collateral ligament, the anterior cruciate ligament, or the medial collateral ligament? So do you guys remember which way varus is and which way valgus is? No? Okay. So lateral collateral ligament. So first order is to clarify varus knees. Varus knee, also known as genu varum, is a condition that affects the alignments of the bones of the person's leg. Larger bone in your calf, the tibia, is misaligned with a larger bone in your thigh, the femur. Common in newborns. And here we have varus right here. So varus is what's called bow-legged, and valgus is knock-kneed. Bow-legged, knock-kneed. Bow-legged. Yeah, varus. Yeah. Oh, look at this. Look, valgus, varus, it's reversed. Oh, look at that. Okay, so now we have to find the actual majority. So we have one for valgus. We have one that says varus is bow-legged is varus. Bow-legged is varus. Bow-legged is varus. Bow-legged is varus. Oh, so there seems to be some confusion about that, some disagreement about that online. Okay, some great stretches and recommendations for movements there. Let me see. Let's find one of these and click on it. Let's see. Let's try ResearchGate. So here they have varus going in and valgus going out. Varus 1A, and it's reversed down here, normal, and then varus, they have varus twice. Okay, this is not good. No more ResearchGate. Valgus versus varus. Let's try orthopedia. Okay, the main function of the lateral collateral ligament that's on the outside is to resist varus displacement. So imagine a ligament on the outside. So these are normal knees. You know that this is the outside because you can see the fibula. And the lateral collateral ligament would be on the outside of the knees like this. So you can imagine that this ligament would be most strained if this side were opened, which is varus, according to them. This is varus. So the sides are opening and the insides are closing. And with valgus, the outsides are closing and the insides are being pried open. A word on terminology, a valgus deformity, which is knock-kneed, a valgus deformity where the medial part opens, is one where the distal part, that's the tibia, is angled away from the midline. Okay, all right, that's good, away from the midline. Varus is one in which the distal part angles toward the midline. At the knee, where these terms are most frequently used, it may be easier to simply memorize that valgus is knock-kneed and varus is bow-legged. Yeah. Okay. So let's just do one more visual for that. So if we consider that varus is one in which the distal part or the tibia is angled toward the midline, then if we look at our own legs, so here's my tibia and here's my femur. And if we look at our own legs, then angling this toward the midline would make it go like this, right? Like that, see? Because this is pointing upward. Can you guys see that? Pointing upward toward the midline. Right? And then varus pointing away from the midline. Varus would be this way. This way. So now let's go back to the question. You know, that kind of thing is a pain, but we have to look at it because what we're training to do here is not diagnose and treat. We're training to take an exam. Okay, so your client suffers from chronic varus stress. And varus, correct me if I'm wrong, please, is where the tibia is angled away from the midline. So that'd be bow-legged. And the client is suffering from varus stress. If it's bow-legged, the space on the outside is going to be opened or stretched, which means the collateral ligament, the lateral collateral ligament would be the one that's stressed. And down here, they just give you the definitions of the LCL and the MCL and what they do, and good luck to you. All right, so I learned something. Okay, to assess the pectoralis minor as a possible thoracic outlet syndrome cause, what test is performed? Travels? That's for the scalene, right? Anterior scalene. Wright's hyperabduction. The Adson's test. Adson's test is for anterior scalene. Travels is for middle scalene. Fausto-clavicular syndrome. That's a syndrome is a collection of symptoms, right? Compression, numbness, and tingling pain. The answer should be Wright's hyperabduction. Pectoralis minor, Wright's hyperabduction. Do you guys want to see a picture of that? You guys want to see like a video of Wright's hyperabduction?
Sure.
Why not? That is popular, also called Wright's test.
Next, to no more than 45 degrees. The arm is then held for 1 minute. The tester monitors the patient's symptom onset and the quality of the radial pulse. The test is then repeated with the extremity in hyperabduction. A positive result is a decrease in the radial pulse and/or reproduction of the patient's symptoms.
To assess the pectoralis minor muscle for the cause of thoracic outlet syndrome, use Wright's hyperabduction test. Start with the client in a seated position, and while standing behind your client passively, abduct the client's affected arm fully to 180 degrees, and then extend the arm slightly, monitoring the radial pulse of the arm. This passive action places your client in a stretch and torsion of the pectoralis minor as the brachial plexus and axillary artery pass through the muscles inferiorly. This test is positive if the radial pulse diminishes or if the client's symptoms recur. Okay, great. Learning these tests. Excellent. Which of the following modalities would allow continuing education credits in the following techniques? Which of the following modalities would allow continuing education credits in the following techniques? Postural evaluation, movement education, fitness training, environmental modification. Like right away, what does that sound like? Not Alexander technique, not acupressure. You guys remember? Aston patterning, also myokinetics and arthrokinetics. Let's keep going. When testing the cervical spine in a seated position, moving the head and neck toward the ground, chin to chest, what group of muscles are assessed in this action? When testing the cervical spine in a seated position, moving the head and neck toward the ground, chin to chest, what group of muscles are assessed in this action? Is it the extensors, lateral flexors, the flexors, or the rotators? It's a top. It could be extensors. Yeah, you're testing the flexibility of the extensors. Yes. Let's see. Yeah, they're saying that it's the extensors because you're actually testing the range of motion or the flexibility of the extensor muscles. There's also an eccentric contraction happening through the extensors and a concentric contraction happening through the flexors. I think the key is the position, the seated position, the testing the cervical spine in a seated position, right? Because the extensors are going to be much more active there rather than in a supine position. If you're laying down, lifting your head up off the table, that's much more activity in the flexor muscles. You have a question, Larissa?
No, I guess my answer would have been flexors, but I was just trying to understand why it was like extensors.
Yeah. Again, I think it's because it's upright, right? So there's a lowering against gravity rather than laying down where there'd be a raising up, there'd be a flexion against gravity.
So if they weren't in a seated position, would the answer possibly be different?
Yes.
Okay.
It could, the answer would be flexors, I think, in my opinion. Like what muscles are you assessing? If the flexors are doing the majority of the work, right, this is a lot more work laying down than it is seated, then I would say that in that case, it's more likely to be the flexors as the correct answer. Okay, the trigger point compression test assesses pain that is caused by what? Trigger points that are activated by movement only and not when the client is at rest. The trigger point compression test assesses pain that is caused by latent trigger points, primary trigger points, secondary or active trigger points that are activated by movement only, not when the client is at rest. So remember latent trigger points. Well, let's read the explanation. So trigger point compression test assesses pain that is caused by latent trigger points that are activated by movement and not rest. Have your client contract the affected muscle then compress the muscle or grasp the skin with a pincher-like technique. Good breathing helps the client focus on something other than the pain and brings oxygen to the muscle. If the pain disappears or diminishes with the compression or pincer, the test is positive for the latent trigger points. Active trigger points are painful at rest and with movement. Latent trigger points produce pain only when palpated or on movement, more commonly. Primary trigger points are directly activated by acute and chronic overload. Okay, so the differentiation that they're making and how the question is phrased is that this is movement only. It's active through movement only. The pain is active through movement only. Primary trigger points would cause pain with movement or at rest. Active trigger points cause pain with movement and with rest. Primary and secondary is a designation of pain referral patterns. Primary causes the main pain referral pattern. Secondary is a trigger point in another muscle within the primary referral pattern. Any questions? Do you guys want me to go over that again? I know I made that a little confusing. Okay. 2 weeks ago, Jane was in a car accident. It was a driver's side head-on collision. She's still very sore and is seeking additional relief from her whiplash symptoms. Jane is having trouble sleeping because of the pain and resorted to taking an oxycodone 4 nights ago. Jane has been diligent in icing and sometimes uses the heat ice contrast as well. She asked for the massage to be gentle, mostly relaxing, with the focus on pain relief in her neck. Of the following treatments, which is best for stimulating the body's natural healing abilities from relief with whiplash symptoms? Which is best for stimulating the body's natural healing abilities? What does that sound like to you right away? Natural healing abilities.
Acupressure.
That's right. Aspen patterning, acupressure, Alexander, or active isolated stretching. Yes. One of your athletes is having pain when performing squats, both on the lowering to the floor and returning to a standing position. What muscles of the coxal joint are being assessed? Lowering to the floor and returning to a standing position. What muscles of the coxal joint are being assessed? Is it the rectus femoris, gracilis, sartorius, and popliteus? Excuse me, the gluteus maximus, gluteus medius, biceps femoris, semitendinosus, and semimembranosus, tensor fascia lata, psoas major, and iliacus, or the gluteus minimus, gluteus medius, biceps femoris, semitendinosus, semimembranosus. Okay, what's the difference between these? Glute max, glute med, glute min, glute med, biceps femoris, semi-sisters.
I think it's the minimus.
You think it's the minimus and the medius?
Yes.
Okay, the coxal joint. All right, let's give it a try. Okay, so lowering to the floor and returning to a standing position. So I think when you think squat, think glutes, but glute max, especially, and think hamstrings, right? It's the big ones in the posterior chain. The glute min and glute med, you can think of those more as stabilizing muscles that keep the knee from going varus and valgus. Which way is valgus? Pointed toward or away from the midline?
I was just trying to think in my head when I do squats, which one I think I feel the most. But yeah.
Oh, yes. You're definitely going to feel certain muscles if you tune into them. And if you, for example, press your knees outward, you definitely would feel that glute med pretty strongly, right? However, the question is, what muscles of the coxal joint? The coxal joint. So, get this. So the coxal joint, muscles of the coxal joint. I believe that is mostly the hip joint. I'm not finding a definition, so let me go to what is the coxal joint? The hip joint. ball and socket type synovial that connects the pelvic girdle and the lower limb. Where's the coxal joint located? The hip joint is the articulation of the pelvis with the femur. Okay, so back to the question. So if it's the hip joint itself, and only the hip joint, because I thought it was the hip joint plus the SI joint. If it's the hip joint itself, then a lot of these, they do act on the hip joint or around the hip joint, right? They do different movements, like the gracilis is one of the adductors, sartorius, not popliteus, but rectus femoris, those act on the hip joint. I would say the best way to discern these two answers, the two best possible answers, glute max, glute med versus glute min, glute med, is to go with the glute max because that's the muscle that's going to be doing most of the work in a squat. Pain when performing squats on lowering the floor and returning to standing position. It doesn't tell you where the pain is, right? It doesn't, that would have been very helpful. If it's SI joint pain or hip flexor pain, that's different from pain inside the hip joint or pain in the semis or pain somewhere in the lower back. Yeah, again, test taking strategy. What is being asked? What are they saying specifically? They're saying squats. What are they not saying? So then what can we deduce based on that? An assessment test may be positive or negative. A positive test is one that must be repeated until pain or symptoms are induced. No. Must be repeated even after pain or symptoms are induced. Does not provoke the client's symptoms, provokes the client's symptoms or reproduces the pain, limitation, or weakness. Provokes the pain, limitations, or weakness. So the reason that that these two are wrong is because it's predicated on the idea that there has to be a certain amount of repetition, which is not the case. Positive tests are always 100%. Like the minute you approach that position, there's pain, right? The minute you start to do a specific position, there's pain. You know, this is positive, right? It's not like, okay, 5 times out of 10, that means positive. 4 times out of 10 does not mean positive. And then not provoking the client symptoms, that is antithetical to the question. All right, your client swims 5 times a week and is now having pain in his shoulder. What tendon, if compressed repeatedly, can cause biceps tendonitis? Pain in his shoulder. What tendon, if compressed repeatedly, can cause biceps tendonitis? Is it the long head of the biceps brachii or the short head of the biceps brachii? Or is it the supraspinatus or the infraspinatus? What is it? Well, let's just look at it. I just want you to look at this for a moment because let's try this one. So we know that the biceps goes through this bicipital groove in the humerus. Let me know if you cannot see this clearly. Goes through this groove, right? And there's 2 biceps, bi, 1, 2. And then another one we know attaches to, I think, the coracoid process. So one goes through here and another goes this way, medial to the humerus. So I'm guessing that the medial one is the shorter one and the lateral one, because it has to go through this groove and starts on the outside and has to reach so far, is the longer one. So let's see what happens. It's the long head. Oh man, that was totally luck. I always confuse long and short heads. And I always confuse like semimembranosus, semitendinosus, which one is which clinically, as long as you know where the trigger points are, as long as you know where everything is supposed to be, is fine. But on a test, unfortunately, you gotta be clear. The neurovascular bundle can be compressed, thoracic outlet syndrome, by the anterior scalene, the middle scalene, the pectoralis minor, or between the clavicle and the first rib. What orthopedic test is performed if the cause of compression of the bundle happens when it passes in between the clavicle and the first rib? in between the clavicle and the first rib. So this is down here, right? Not where the anterior or the middle scalenes are located. So we know it's not going to be Adson's for the anterior scalenes or Travell's, which is for the middle scalenes. Again, costoclavicular syndrome is a collection of symptoms, right? Hyperabduction we just saw is for the pectoralis area. Let's see what it says. Costoclavicular syndrome test. The costoclavicular syndrome test is performed while the client is in a seated position while standing behind the client, passively depress and retract the shoulder on the affected side. Yeah, let's take a look at that. So the thing is, look at the wording: Adson's test, Travell's, Wright's hyperabduction, costoclavicular syndrome, and then look at the explanation. Oh, the answer is the costoclavicular syndrome test. Sorry, we forgot to leave that word out of the. I don't think they're going to do that to you. Don't worry. I don't think you have to worry about that, but depress and retract the shoulder on the affected side. Again, not great wording. So that's what I'm here for. Depress and retract the shoulder blades, right? You retract shoulder blades. You don't actually retract the shoulder joint, right? And then make sure to monitor the radial pulse on the affected side. The test is positive if the radial pulse diminishes as you retract and depress the shoulder blades. So here's elevation, and there's protraction, and the proper test is retraction, and I think he said some depression. So there's a little depression there. He presses down a little bit. Okay. So probably can hear that my 14-year-old is having a moment right now where his appetite for salami is exceeding his common sense and his courtesy. Yeah, who's 14? We're talking about you. Okay, Marge has not been feeling like herself lately. All the traveling to different family events has impeded her regular eating and exercise routine. The stress of being away has created imbalance in her lifestyle. She would like to rewrite her natural constitution and gain health and well-being. What treatment modality will restore her health through balance in lifestyle, diet, and exercise? Wow, that's pretty comprehensive. Lifestyle, diet, and exercise. You're not going to get that through aromatherapy or body rolling. Those are a little too specific. Ayurvedic body work doesn't really have a whole lot to do. Yeah? Okay. All right. Let's see.
No, I was agreeing with, like, yeah, it's that. And the only reason I thought about that, and it probably doesn't really work for anybody else, but I thought about where it comes from and like how they're into like diet and stuff like that. So it just makes sense that way.
Yeah, and it's exactly, that's exactly the right thinking. They define Ayurvedic as life or life principle, knowledge of life, right? And also, if you look at the other choices, even though it may not be, if you look at the other choices, it becomes a little more obvious because active isolated stretching is very specific only to flexibility in joints. Body rolling is specific to the fascia and the muscles. Aromatherapy, that can have an internal and a nervous system effect, but it doesn't have anything to do with diet or lifestyle or exercise. So process of elimination would lead you to something a little bit more comprehensive. But again, the answer is not quite specific enough. Okay, let's keep going. Let me see how many of these questions from Yugo Prep do we have left? Yeah, well, okay, I want to get to these down here, which are from AMTA. They just have a little bit different, they have different phrasing. So it's just like get through these. We'll do this for 10 more minutes and then we'll take a break and then we'll switch to AMPA. Does that sound okay? Which term would be used to describe the positioning of the hand in relation to the shoulder? Is it distal, medial, proximal, or lateral? Which term would be used to describe the positioning of the hand in relation to the shoulder? Is it distal? Is it medial? Is it proximal? Or is it lateral? Which one would be distal? What two actions comprise inversion, ankle inversion? Would that be plantar flexion and pronation, supination and adduction, dorsiflexion and pronation, pronation and adduction, supination and adduction? The term medial refers to structures distal to the midline, proximal to the midline, distal to the side, or proximal to the side. Is that distal to the midline, proximal to the midline, distal to the side, or proximal to the side? It's always relative to the midline, never to the side. So medial would be proximal to the midline. A strange way to say it. Proximal to the midline. So consider that proximal is toward the center, distal is away from the center. Okay, Amanda is normally very motherly and thoughtful. However, lately she has been very complacent, a little depressed, and is gaining weight. It has also been difficult for her to wake up in the morning and get her sinuses not been clear for months. She feels out of balance and wondered if you had any ideas to help her regain her vitality. What treatment modality will help Amanda obtain a treatment plan that includes diet and exercise to assist her in rejuvenating? Orthopedic massage, Ayurvedic bodywork, aromatherapy, or body rolling? Ayurvedic bodywork of the 4 choices. While giving an assessment, there are 3 types of questions you ask. General, specific, and pain. Which of the following is a general question? What is your present level of stress? How long has this degree of stress been present? Was there medical treatment or therapy given prior to coming to getting a massage? What is the nature of the pain? How painful is it? Mild, moderate, or severe? What is your present level of stress? How long has this degree of stress been present? The Adson's test, Adson for the anterior scalenes, Travels for the posterior scalenes, thoracic outlet syndrome test for the space between the clavicle and the first rib, and the Wright's hyperabduction test for the pectoralis minor. Which test assesses the middle scalene? Meaden's test, look at that. Travels test. Triceps brachii has one action on the elbow or humero-ulnar joint. Humerus, ulna, humero-ulnar joint. And 2 actions on the glenohumeral, glenohumeral, or shoulder joint. What is the one action all 3 heads perform at the elbow? All 3 heads perform at the elbow. Is it extension? Is it flexion? Lateral rotation, that would look like that. Or medial rotation, that would look like that. We know it's not this one. We know it's not lateral and medial rotations. Got to be flexion or extension. Those perform extension. In a cardiac emergency, after you have successfully recognized a heart attack and called 911, you can lessen the damage to a conscious person who is showing early signs of a heart attack by continued CPR, assist them with taking an aspirin, use of another defibrillator treatment, or continued abdominal thrusts. Assist them with taking an aspirin. Conscious person. So here, another tricky question. All right, cardiac emergency. You're probably thinking heart attack, the heart is stopped, the person's not breathing, administer CPR. Successfully recognized a heart attack and called 911. You can lessen the damage to a conscious person. So the person is having a heart attack, but their heart is still beating. They still have a pulse and they're still breathing. So you don't give CPR to someone who has a pulse and is breathing. You can give them an aspirin. You know, no massage therapist in their right mind, unless they want huge liability, is going to give someone any kind of medication, especially if they're having a heart attack. But again, this is not clinical. This is exam question. use of another defibrillator treatment. There's no context for the first one. Continued abdominal thrusts, you wouldn't do that. Interesting, right? Okay, full and normal range of motion requires appropriate functioning of all tissues. Full and normal range of motion requires appropriate functioning of all tissues. In active range of motion, what must happen to the bones in assessing proper function? The bones must stabilize the joint and allow the joint to move. The bones must articulate to create the appropriate joint action. The bones must fire or shorten to create the movement. The bones must lengthen to allow joint movement. Must be articulate to create the appropriate joint action. While giving an assessment, there are 3 types of questions you ask to obtain relevant information. General, specific, pain. Which of the following is general? How is your health in general compared to, was there medical treatment or therapy prior to coming? How painful is it? What are your current medications? Muscles have been categorized into 2 groups when dealing with postural dysfunctions, postural and phasic. Which of the following muscles are primarily phasic? Gastrocnemius pectoralis minor, soleus and hamstrings, piriformis quadratus lumborum, serratus anterior and middle trapezius, and of those, serratus anterior and middle trapezius. Larissa, I know that you and I have gone through these in the first class that you took. Charday, have we gone through postural and phasic muscles in this class?
No.
Okay, so let's take a look at those now, because this is definitely something worth establishing context for. So this is in the doc called assessment. It's called this like assessment study guide. Tell me something. Are you guys able to access these documents? Okay. I noticed that not a lot of people are using them, and I'd like to know if there's anything in the way, technically. Okay. So postural and phasic muscles. So the characteristics of postural muscle is that they're anti-gravity. They work to lift things or to push your body away from gravity. And they have higher tone as a result. They have higher tone than phasic muscles. They're the ones that tend to get short and tight. So think upper trapezius muscle, glutes, hamstrings, glute max and hamstrings. Let's see, genetically older and less reactive to injury. You don't need to know that. Atrophy less quickly than phasic muscles. I don't think you need to know that. Okay, so anti-gravity tonic muscles tend towards shortness and tightness, higher resting tone. Phasic muscles are, they don't oppose demand. They don't oppose gravity, excuse me, they don't work against gravity. They tend to be the ones that become weak, that become inhibited, underused, not firing. So a phasic muscle, thank you very much. So a phasic muscle in our example would be the middle trapezius rather than the upper trapezius. The middle trapezius tends to act in shoulder blade retraction, more open upright posture. And the serratus anterior brings the tip of the shoulder blade down and forward a little bit, and also stabilizes the ribs in some arm positions with breathing. Compare that to the upper trapezius, which definitely works against gravity. The piriformis muscle and the quadratus lumborum muscle. We'll come back to those. The soleus and the hamstrings, those are definitely working against gravity. The gastroc and the pectoralis major also working against gravity to move loads. So let's look at a few examples of these. Also, I'm curious about I want to find out if the piriformis and the QL are considered postural or phasic. So contrary to the name, postural means it moves a load against gravity, higher resting tone, and they tend towards shortness and tension. Phasic are what we think of as the postural muscles. They don't work against gravity. It tends towards long lengthening and getting weak or inactive. So the phasic muscles are the scalenes, The lower fibers of the pec major, the deep muscles of the neck the deep muscles of the neck, the longest colli and capitis, and then the middle trapezius and the lower trapezius. Rhomboids, serratus anterior, some of the abdominals, glute max, glute med, glute minimus. So all three glutes tend towards weakness, lengthening, and inactivity. Okay, and then the gastroc, the soleus, the tibialis posterior, those are all postural, meaning they work against gravity. They tend to get short and tight, and they have higher resting tone. The piriformis is among those, as is the quadratus lumborum, pectoralis major, the upper portions of the pectoralis major, the lower portions are phasic, the upper portions are postural. They work against gravity more. Erector spinae group, the levator scapula, upper fibers of the trap. Yeah, this is great. This is a short, easy to understand read by Nazem. It's in this assessment doc down at the bottom. Check it out. Oh, finally. Okay, let's take a break. How long do you want your break to be? Sorry, there's technical stuff today that ate up part of your break. Do you want 5 minutes or 10 minutes?
10 is fine.
10 is fine. Is that okay, Larissa?
Yeah, I'm fine with that.
Okay, great. 10 minutes. Okay, so come back at clock at 7:26 Eastern Standard Time. 7:26 Eastern Time. Okay. All right. Thanks, guys. I'll see you in. And resume recording. Goes and back to the presentation. Okay, for this section, we're going to go with PDF because the Zoom is more hospitable. I want you guys to be able to read. All right, so from the AMTA under the assessment section, they have like 100 or so questions. And I got, I think, 30 of them down for presentation tonight. All right, during which phase of tissue healing is it most appropriate to focus on the development of strong scar tissue, restoring firing patterns, and reducing compensatory patterns? During which phase of tissue healing is it most appropriate to focus on development of strong scar tissue, restoring firing patterns, and reducing compensatory? What's that?
Early subacute.
I would just go with the simpler one, right? Rather than a division of subacute, the division of acute or division of chronic, I would just start with either acute or chronic. Let's see what they say. The chronic phase of tissue healing focuses on the remodeling of tissue and occurs 3 to 12 months after an injury. The healing tissue is no longer fragile and collagen is laid down along the lines of stress. Therefore, developing scar tissue along appropriate lines of stress to improve mobility will be beneficial in this phase, as well as improving firing patterns and reducing compensatory ones. The acute phase should focus on managing pain and improving sleep, while the subacute phases should focus on managing edema, pain, scar mobility, and compression patterns. It is not until the chronic phase that the focus shifts to developing strength and scar tissue. Chronic phase, strength and scar tissue. When assessing a client for fluid imbalance, what is the first step the massage therapist should take? What do you do first when assessing a client for fluid imbalance? Observe the tissue for changes in color. Ask the client for their history regarding injury or swelling to the area. Ask the client if the tissue feels stiff, fat, or distended. Palpate for heat over the area. What should you do first? Ask the client if the tissue feels stiff, fat, or distended. Understand that on this app, the box in red is the incorrect answer if I tap it, and the box in green is the correct answer. When assessing for fluid imbalance, the therapist should ask about the client's subjective experience before performing a physical assessment. The first step is to ask how the tissue feels. The answer to this question can direct the therapist to a specific area of the body. If the answer is no, it does not feel distended, stiff, or fat, then a therapist can palpate to ensure that no swelling is present. When assessing areas of pain, it is important for a massage therapist to differentiate between joint and soft tissue dysfunction. Which is an indication of a joint dysfunction? Is it pain with joint traction and active range of motion? Pain with joint compression and passive range of motion? Pain without joint movement? Pain only with deep palpation? And the answer for this one is pain with joint compression and passive range of motion. So pain with joint compression is usually joint dysfunction. Pain with joint traction is usually soft tissue dysfunction. Traction stretches the tissues. Joint compression presses the joints together. So if there's cartilage breakdown, if there's bone spurs, arthritis, a fracture, joint compression will increase the pain from those causes. It won't increase the pain from a stressed or torn tendon or muscle. That's probably just going to be painful constantly. But if you stretch that, if you stretch something that's torn, it'll definitely increase the pain. Fill in the blanks. Price stands for blank and is an appropriate treatment during the what phase of an injury? Protection, relaxation, ice, compression, and elevation during the acute phase of injury. Protection, rest, ice, compression, and elevation during the chronic stage of injury. Protection, rest, ice, compression, elevation during acute. Pain, redness, immobility, contusion, edema during subacute. So price, P-R-I-C-E. And this is appropriate treatment, an appropriate treatment. So pain, redness, immobility, contusion, edema, that's not treatment, that's a description of symptoms. I would say it's got to be this one, protection, rest, ice, compression, elevation during acute. So what's the difference between these two? Protection, relaxation. Okay, the word relaxation versus rest. The standard word is rest. Protection, rest, ice, compression, elevation. Yeah. Okay. A client expresses her desire to remain modest and that she does not feel comfortable disrobing for a massage intervention. What is the most appropriate solution? We find I have guys like this too, I have males and trans people like this too. Provide the client with a written handout describing the benefits of massage as applied directly to the skin. Instruct the client to wear loose-fitting shorts and a shirt for the session. Provide a demonstration of draping on a colleague. Refuse treatment. Instruct the client to wear loose-fitting shorts and a shirt for the session. 1 week ago, a client was diagnosed with a quadriceps strain after running a marathon. Which technique should the massage therapist use to most effectively aid in the healing process? Circulatory massage, gliding techniques, friction massage, or contract relax techniques? What do you guys think?
I'm thinking, and I want to say it's either, I'm going to just go with gliding technique, but I also think contract. Oh, I was right. Okay.
You are right. Yes, yes. But you're thinking contract relax as well, maybe?
Yes, because it's so tight. I was thinking about that.
Mm-hmm. Mm-hmm. Yeah, might not be bad, contract, relax techniques, but a strain 1 week ago. So it's still acute, and a strain implies what's happening with the quadriceps muscle, Charday. That there's some tearing.
Right.
Doesn't have to be a lot, but okay. A strain is a tear in a muscle and can occur to varying degrees based on the grade of the strain. Grade 3 being complete tear. Therefore, the techniques to bring the two ends to the tear closer together will help to heal the tissues faster. Gliding techniques can achieve this, and the technique should be applied with pressure moving towards the epicenter or the most painful area, not away. Circulatory massage, this is interesting, can help with tissue healing, approximating or bringing the ends together. Tissue would be more effective in a strain since the injury occurred as a result of a separation of two parts of the muscle. Friction massage may reduce pain perception, but this will not aid in healing in this instance. Contract or relax techniques would not be appropriate this soon after a strain, since this would tense or lengthen the muscle and hinder healing. So if there's tearing already, you want to avoid lengthening the muscle. Have the client dorsiflex the yeah, okay, all right. We're skipping that one. After an initial assessment is completed with the client, the massage therapist asks if the client is agreeable to beginning general massage, to which he says yes. Treatment is then begun immediately on the lower back with trigger point release and kneading. Several days after the session, the client calls the clinic upset because his back pain is worse and he never agreed to trigger point release. How could this situation have been avoided? Oh boy. By reducing the rigor of the techniques initially and avoiding treating the lumbar region, by having the client sign an informed consent form and speaking with the client about possible side effects prior to massage, by not performing trigger point release, this client should not have been treated at all. And the answer is,
I'm sorry, I have a question. So with
yes.
that, like, should you just put that on your paperwork that they sign? Should you just put that on there, or do you just specifically?
Yes.
Okay.
No, I'm sorry. I'm saying like, yes, go ahead, finish your sentence.
Oh,
or do you specifically what, verbally ask
yeah.
them? Are you aware of the risks of massage? Yeah, I would do both.
Okay.
Yeah, when I have a client, you know, I'm an acupuncturist. I also do body work. I do joint mobilizations, nutrition. When a client calls, I always give them kind of a verbal informed consent over the phone, and then I have them read and sign one. And most of them, they don't read the informed consent. They just want to get that nonsense out of the way so they can get to their session. Yeah, but you're gonna get plenty of people who are like, you know, you're gonna get people for whom they're gonna need to know that certain techniques may cause redness or bruising. Certain techniques may result in greater pain in the meantime before it gets better, right? Or that certain techniques may involve oil or heat.
Yeah.
You know, they might have really, really sensitive skin that could react to like any kind of oil. And there's always, yeah.
Do you get to a point, because I know like in the beginning, well, I know for me in the beginning, I'm gonna have to keep referencing the book as far as like the do's and don'ts of what to massage and things like that. Does it get to a point to where you start memorizing that stuff? And I know you are, but I know it's so much, it's such a big range.
Yes, it is. It is. You can narrow it down by thinking about your scope of practice, right? So if you work on adults, children, pregnant people, and elderly for palliative care or cancer patients, then that's like a very, very big range. You know, you have to go through them one at a time. What do children and their parents need to know? What do adults need to know? What do pregnant women need to know? What are the risks in each of those categories, right? So I would start small at first. Don't try to treat everybody. Just like strictly in terms of informed consent, right? Like before you take a prenatal client, make sure you have all the risks well in mind, and you have something on paper, and that you've interacted with your malpractice insurance and said, you know, look, do you have a malpractice policy for prenatal clients? Can I see it? For pediatric clients, you know, where do I find that? And they will have exclusions in there. You know, they'll list specific things, you know, that they don't cover, situations that they don't cover, right? So then you have to decide which ones you're going to accept as a risk and go ahead and treat them even though the malpractice insurance doesn't cover it, and which ones you're just going to not touch for now because it's too complicated. Just try to keep things really simple. If you start with like physical, like chronic pain and injuries initially, that's a narrow range, and it's a lot easier to kind of control for the side effects. So, and then I would say, even if you didn't do that, even if you didn't think about like everything that you're going to treat and how broad or how narrow the range is, and all of the everything people need to be aware of, and you need to be aware of in informed consent risks, et cetera. Even if you don't think about that, still your communication efforts can really keep everyone protected and really like save you and the client when it really matters. So make sure that you have an informed consent that is this is my recommendation, that's written in language that you understand, right? It's no good to use words like petechiae if you don't know that looks like a bruise, right? Don't tell someone they're going to have petechiae on their back from like a cupping technique if they don't understand they're going to be bruised, and then come to find out they have a wedding with an open back dress a week later, that kind of thing. True story. Not in my clinic, one of my teacher's clinics, but you know, use language that you understand, and always ask them beforehand. So you know that this tapotement technique does come with the risk of a dropped lung or a pneumothorax, right? You know, is that a risk that you're comfortable with taking? I've never seen it. I don't know any of my colleagues who've seen it. I've read like in the documented literature, I've read of like 1 or 2 cases. We never saw it in school, but it is a risk, and I want you to know it. You know, like just all kinds of stuff. You know that with this technique or that technique, there's the risk of infection. There's the risk of bleeding or bruising. You know, always inform them verbally. And you know, you can't have, yeah. Okay. Okay, so by having the client sign an informed consent form and speaking with the client about possible side effects prior to the massage, it is extremely important to obtain informed consent in various ways prior to starting a session. The client should sign a form before the massage begins, and the therapist should obtain verbal consent both before and during the treatment itself. If the treatment plan should also have been discussed in as much detail as necessary to ensure that the client knows what to expect. While reducing the rigor of techniques initially might be a good idea, obtaining informed consent is even more important in this instance, since the client was upset that he was never given the option to turn down trigger point release. The client still should have been treated as long as informed consent was obtained. So going back to the original question, after initial assessment, are you agreeable to general massage? She says yes. Treatment begins immediately on the lower back with something more than general, which is something very specific. Trigger point release and then kneading. And the client doesn't have a chance to decline those options because He wasn't informed. They were not informed. Which of the following patient situations would benefit most from palliative care from a massage therapist? A 35-year-old woman with fibromyalgia, a 25-year-old pregnant woman in the second trimester, a 50-year-old basketball player with knee pain, or a 48-year-old woman with terminal pancreatic cancer. And that should be the patient who has terminal pancreatic cancer. When working with a 14-month-old child, the massage therapist noticed that the child's respiration rate increases from 21 breaths per minute to 35 breaths per minute, from 21 to 35. Her facial expression changes to a frown with a clenched jaw. The child's mother is also present, and she says not to worry or change anything because the child does this frequently. What are the best next steps for the massage therapist? Completely stop the massage, refer the client to a physician. Completely stop the massage, attempt again next week. Continue with the same technique to the same area, reduce the current pressure, move to a different area of the body. What do you think?
Refer the client to a physician.
Okay. What makes you think that the client needs to be assessed by a physician for something that you cannot assess or identify?
That makes sense that it can't be that one now, because what you just said just made sense. Like, if you can't really say what it is, so I guess you would just
more so, what are you seeing in your patient
discomfort.
that is
Yes.
And are you trained and equipped to try something else to see if the discomfort changes?
No.
You're not?
Oh, to see if something else changes. Yes.
To see if the discomfort changes? Yes. You're going to have plenty of clients who are like, oh, that hurts. Is that supposed to hurt? The only difference is a 14-month-old can't say that. They'll just say like, owie, 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 massage bad. Okay, so the answer is reduce the current pressure and move to a different area of the body. So let's look at them again. It's this one here, reduce the current pressure, move to a different area of the body. If you lighten the pressure and move to a different area of the body, does the facial expression change? Does the child relax? Is the child in less discomfort or no discomfort or same discomfort? You can assess that for sure. Completely stops massage, refer the client to a physician. That's panic mode. It's like not thinking. Cause and effect. If this, then what? What if I change this? Then what? Completely stop the massage. Attempt again in 1 week. Continue with the same technique to the same area. No. And the mother is saying in the example, the mother's saying, don't change anything. The child does this all the time. You are the authority. You have to actually assess and treat and amend, like alter, and decide what changes and what doesn't. If you notice that a client's alignment is faulty with deviation in the frontal plane, what are you visually assessing? The client's restrictive range of motion, the client's walking pattern, the client's basic balance, or the client's posture? The frontal plane. Always forget the planes. Frontal plane of the body. Frontal plane, this way. Frontal plane. How do I get back to the restrictive range of motion, the client's walking pattern, basic balance, or posture? So the frontal plane, imagine what can happen to show deviations or to show changes in this plane, right? This plane is perfectly straight, the client is perfectly upright. What if the client is kyphotic? Can you envision how the plane would bend right there? It would bend forward. So that'd be a deviation in the shape of the plane, right? Transverse or horizontal plane, if the client stands with one hip hiked or one shoulder way up, can you see how that would be a deviation in the transverse plane or horizontal plane? Mid-sagittal or midline plane, also one hip hiked, would show a deviation in the midline plane, right? Neck to one side, deviation in the midline plane. So are we looking at, with the frontal plane, are we looking at restrictive range of motion, walking pattern, basic balance, or posture?
The client's posture.
Posture, yeah, very good. Very good. If you notice a client's alignment is faulty with deviation in the frontal plane, you are visually assessing the posture. If you notice the client's gait is smooth and balanced, you're visually assessing client's walking. If you notice the client is unable to reach beyond his base of support, you are assessing his balance. That's not very useful. Good try, MTA. Massage therapist notices the following findings after an initial session. 150 degrees of shoulder flexion passively on the right. So that's probably 90. So that's probably somewhere like around ear level, below ear level on the right, and then increased rounding of the mid-back, pelvis tucked under the spine, pain rated at 5 out of 10. What's the most appropriate way to document these findings? So they want to ask you about documentation. Client rated pain at 5. So what would you write in your chart? Client rated pain at 5 over 10, 5 out of 10. Increased thoracic kyphosis, postures in posterior pelvic tilt, passive range of motion of right shoulder 150 degrees. Or would it be pain rated 5, rounded mid-back and tucked pelvis, 150 degrees shoulder flexion? Or would it be P exclamation rated 5 out of 10, thorakyphosis, PPT present, shoulder flex 150 deg on right. Client first rated pain is moderate. Client has thoracic kyphosis as well as tucked pelvis, 150 degrees of shoulder motion was available. So I'll just give this one to you. It's the first one, and the reason is when documenting a client's progress, it's important to be as clear as possible. Use precise medical terms as much as possible. Abbreviations should only be used if they are universally accepted. And RTD, Thor, and PPT are not universally accepted. The pain level should also be reported as the client described it rather than converting a 5 to 10 rating as moderate in the notes. Use medical terminology rather than rounded back and tucked pelvis. So posterior pelvic tilt compared to tucked pelvis. Increased thoracic kyphosis compared to rounded mid-back. Cancer patients use massage as invasive treatment, primary care, direct therapeutic care, or complementary care. And the answer is complementary care. They use it in order to enhance the healing process. Palliative care is used for pain relief and relaxation for clients with terminal diseases. These clients often, but not always, have a diagnosis of cancer. Direct therapeutic care is used for direct muscle relaxation or stimulation. Invasive treatment does not include massage application, as massage is non-invasive. It doesn't go inside the body, piercing the skin. When assessing a client for a range of motion, the massage therapist notices the client has 5 degrees of hip extension. What would be an appropriate intervention to improve this? Contract and relax the psoas, then contract the gluteus maximus while moving the client into hip extension. Contract and relax the psoas, then contract the glute max while moving the client into hip extension. Contract and relax the glute max, then contract the psoas while moving the client into hip extension. Contract and relax the psoas, then contract the gluteus max while moving the client into hip flexion. Contract and relax the gluteus maximus, then contract the psoas while moving the client into hip flexion. So 5 degrees of hip extension. So the limitation is in extension. So you probably want to work which way, into extension or flexion? Extension, yes. And are you going to, so extension is achieved by what, the glutes or the psoas? The glutes extension, the glutes. Psoas is in the front, glutes are in the back. Extension is the leg going behind you, like Look at this. Extension. Okay, so they probably need to contract the glutes and to relax psoas in extension. Let's see if one of these two, which list extension, the last two list flexion, have that answer. Contract and relax the psoas, then contract the glute maximus while moving the client into hip extension, versus contract and relax the glute max, then contract the psoas while moving the client into hip extension. The psoas will oppose the hip extension. So I think it's the first one. Yeah, it's contract the glute maximus while moving the client into hip extension. Contract and relax the psoas, then contract the gluteus maximus while moving the client into hip extension. Given the available information, it's likely that a shortened psoas is the cause of this client's decreased hip extension. One way for the therapist to improve the length of the psoas is by using the contract, relax, antagonist, contract muscle energy technique. This is performed by first having the client contract the targeted muscle, the psoas, then relax, followed by contraction of the antagonist, the gluteus maximus, while stretching the target tissue. In order to improve the length of the psoas, the client must be moved into hip extension at the end of this technique, not hip flexion. The target tissue in this case is the psoas, so this must be contracted first, not the gluteus maximus. What a well-crafted explanation. After 5 massage sessions with a focus on stretching, a client still presents with decreased range of motion when they perform knee flexion. What technique might the therapist perform next to enhance the effects of stretching? The next one is all the questions. Yeah. Continue to stretch the quadriceps, then use contract relax techniques of the quadriceps. Oh, let me read that again. I need to read it again. I'm sorry. 5 massage sessions with a focus on stretching. A client still has decreased range of motion when they perform knee flexion. Knee flexion. What technique might enhance the effects of the stretching? Continue to stretch the quadriceps, then use contract relax techniques for the quadriceps. Use contract relax techniques for the quadriceps, followed by stretching of the quadriceps. Ooh. Continue with the same plan and techniques since 5 sessions are not enough to notice change. Use only contract relax techniques for the quadriceps. Very interesting. So I think it's either B or D. B or D. What do you think?
B.
Yeah, I think so too. Use contract relax techniques for the quadriceps, followed by stretching of the quadriceps. Nice. Okay, let's find out their rationale. If a client has not improved after 5 sessions, it's time for the therapist to use a new strategy. Stretching is most effective when used after contract relax techniques of the restricted tissue. If the knee is limited in flexion, contract relax of the quadriceps, followed by stretching the same muscle group, would be the most effective strategy. To enhance the effects of stretching, contract relax techniques should be used before stretching, not after. This technique is also most effective when used in combination with stretching. 5 sessions is enough time to see a noticeable change, so a change in technique or focus is necessary. A client comes to a massage therapy clinic after falling on her wrist 3 days ago. Her physician has diagnosed her with a wrist sprain and has approved massage therapy. Upon assessment, the wrist appears visibly swollen, is painful, slightly warm to the touch, and an impression is left on the tissue with palpation. What is the most appropriate treatment for this client? Venous drainage for the area, stretching of the wrist into flexion and extension, lymphatic drainage for the area, light passive range of motion, full body massage, lymphatic drainage for the area, contract relax techniques for all ranges of wrist range of motion. This client is not yet a candidate for treatment. Some interesting choices there. All right, let's see what they say. So that is lymphatic drainage for the area, light passive range of motion, full body massage. Lymphatic drainage for the area, light passive range of motion, full body massage. So let's look at elimination first. Why these others are not appropriate. Okay, after falling on her wrist 3 days ago, that's acute, right? The physician diagnoses her with a wrist sprain, which is important. There's a physician there making the diagnosis. That means that legally she has a wrist sprain until the MD proves otherwise, which is a crappy system. But more on that later, maybe. Now, venous drainage for the area, not a bad idea, but stretching of the wrist into flexion and extension 3 days after a joint strain, 3 days after strain, not a good idea. Sprain or strain? Okay, either one, sprain or strain. Sprain. 3 days after sprain, not a good idea. Light passive range of motion. Think about what that looks like. Very light rotation, very, very light, slight deviation, very light, slight. Light also implies minimal to no pain, right? And then a full body massage. Full body, you're treating the whole person, treating the nervous system, treating the lymph and blood flow in the center of the body, right? Treating areas where there may be compensation from the chain working differently. Lymphatic drainage for the area, contract, relax techniques for all ranges of wrist range of motion. Okay, again, contracting and relaxing would shorten the muscles and probably not a good idea at this time, 3 days after the injury. There's all kinds of pain. This client is not yet a candidate for treatment. You know, this is a tendinomuscular injury. This is what you're trained for. Lymphatic drainage for the area, light passive range of motion, full body massage. This injury is still in the acute stage of tissue healing. Swelling, heat, and pain are all very common symptoms of a recent wrist sprain. The presence of pitting edema further confirms swelling in the area. Lymphatic drainage is an effective treatment for this condition. Light passive range of motion to reduce pain levels and full body massage to promote healing are both appropriate in this stage of healing. Even though some heat is noticed in the area, it is still appropriate to treat this client since she has been cleared by her physician and the joint does not demonstrate any visible redness. Venous drainage would be most appropriate for congestion rather than swelling. Stretching and contract relax techniques are appropriate for the late subacute and chronic phases of healing, not the acute stage. Okay, that is all the time that we have tonight. Still lots of questions for the assessment that we can get through. They're all available to you in the Google MBLEx section. Please go look at that. Just need to exit full screen. Yes, in the MBLEx section. What would we do? Where's the damn? Losing my mind.
Is it possible if you can resend that folder to my email?
Yes, sure.
Thank you.
No problem. You're welcome. All right, have a great night. I'll see you guys on Wednesday.